to cover 40 questions. Okay. 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 Now I'm going to share my screen with you. Okay. Let's start with question number one. Like always, start from the last line. Which of the following is the most likely cause of these patients' symptoms? Okay. Then afterward, read all the options. Give one rate to the options: adrenal, adenoma, carcinoma, Cushing, small cell lung cancer. Okay. Now read the whole question. Age 56-year-old woman, progressive weight gain, fatigue over the last four months. She also had increasing difficulty in lifting heavy objects and climbing stairs. Difficulty lifting heavy objects and climbing stairs. The patient has moderate persistent bronchial asthma for she used inhaled corticosteroids and beta 2 agonists. Family history is inhaled corticosteroids and beta 2 agonists. Family is significant for colon cancer. His blood pressure is 160 by 90. Pulse is, pulse is 80. There is symmetrical proximal muscle weakness. Okay. The patient has symmetrical proximal muscle weakness, like the weakness is at his shoulder joint and its hip bone joints. That's why it has difficulty in climbing stairs and lifting heavy objects. Okay, so it is very specific for one specific pathology. Fasting plasma glucose levels are also elevated. 24-hour urinary cortisol levels are also increased. High dose but not low dose dexamethasone suppresses serum cortisol levels. Serum ACTH levels are high normal. So what is the diagnosis here?
Cushing syndrome.
The
Cushing
patient has
disease.
Cushing syndrome, but because that's why his cortisol levels are elevated. 24-hour urinary cortisol levels are elevated, and that can also explain the weight gain here. That can also explain the proximal muscle weakness here. That can also explain the high levels of glucose here. Okay, all of these things can be explained by the increased level of increased level of cortisol. Now what he is asking in this question, what is the cause of the high level, what is the cause of that high level of cortisol? Where is the main pathology site here? Is it within the, is the main pathology site is within the adrenal glands? Is it within the pituitary gland, or is it there's an ectopic side which is the main cause of the high level of cortisol here? Okay, so if the main pathology site is within the, is if the main pathology site is within the adrenal gland, what will be the natural response of the pituitary gland? What will be the levels of the ACTH if
It will
there
be
is a,
down.
it
Down.
will be less if the
Less.
cortisol production is due to if the cortisol production is high due to an adrenal adenoma, the natural response for pituitary is to decrease the ACTH levels, right? Is to decrease the ACTH levels. Okay, but in our case, what is the value of ACTH? The patient serum ACTH are high normal. They are high normal. Okay, and in the question he has described that high dose but not low dose, high dose but not low dose dexamethasone suppresses the serum cortisol levels. Okay, so because his ACTH levels are high normal, that eliminates that the main pathology site is not within the adrenal gland. Okay, we are dead sure that it is not the main pathological site is not within the adrenal gland. because if it is in the adrenal glands, the ACTH should be low. That means that the pituitary is not, whatever the side that is producing the ACTH is not working right. Okay. And now we have to differentiate whether the ACTH producing site is within the pituitary or not. Okay. So does you know how does the dexamethasone separation test works? Do you people know?
No.
Okay. Okay. I will let you know how
If
does the
the patient
dexamethasone.
test was positive, it will be pituitary.
Yeah, if high dose suppresses the high dose, if high dose, what is dexamethasone? Dexamethasone is steroids. It is cortisol. Okay, it is another name for a steroid, same like the cortisol. Okay, if you are giving a high dose steroid and the ACTH levels drop, that means that the site is in the pituitary. Okay, and if it is does if the ACTH level does not drops even after the high level of steroids, that means that the ACTH producing site is not within the pituitary. Can you name me a cancer in which the ACTH is high, which
Lung
which also
cancer,
produces ACTH? Can you
small
name me a cancer?
Small cell cancer.
Adenocarcinoma.
Yes, small cell lung cancer. In small lung cancer, we also see high levels of ACTH. Okay. And any other cancer other than small cell lung cancer, do you know? Okay, first we see, okay,
ADH level also increase.
yeah, ADH levels also increases. Okay, Cushing syndrome. Okay, okay. Do you think it is tertiary? Do you think it is tertiary the tertiary level of hypercortisolism? Do you people think that the
yes,
main cause is can be due to the exogenous glucocorticoids here? The patient is taking corticosteroids here.
yes, can be.
It might be.
Yeah, the patient is taking inhaled corticosteroid. Do you think that can be the cause here?
No, I don't think so
Yes,
because
that
it's
could be.
inhaled, so it's not systematic.
Yes, remember, only oral steroids can be the cause of tertiary hypercortisolism. Oral, never inhaled, because inhaled corticosteroids go on a very low level in your blood circulation. Most of their effects are at a local level. Okay, that's why inhaled corticosteroids can never be the cause of hypercortisolism. Okay, if it were a oral corticosteroids, then the case would be different. Okay, so that's why exogenous, you can remove the exogenous glucocorticoids from here. And we have seen that it is not the adrenal glands are not the main pathological site here, because the ACTH levels are high. Okay, so we are left with two options, D and E. Now we have to see differentiate the ACTH producing site is whether in the pituitary or is it at ectopic site. Okay, can you see this graph?
Yes.
Okay, ACTH dependent Cushing syndrome. First, measure the serum ACTH. We have measured it is elevated. Okay. Now, when you know it is elevated, now we have to see where the ACTH is producing from. We will do the dexamethasone suppression test. Okay. There are two tests. We can do CRH stimulation test and dexamethasone suppression test. Okay. If after giving the high dose dexamethasone suppression, after giving high dose of steroids, the ACTH level does not drops. That means ACTH is producing at an ectopic site. Any other site other than pituitary is an ectopic site for ACTH production. Okay. Okay. And in our question, does the ACTH levels drops? It is suppresses the serum
No.
levels. Okay, so it is not an ectopic site. Okay, so it is not an ectopic site. Okay, let's see the other possible scenario. If the ACTH level drops, then it is Cushing disease. Do you know the difference between Cushing disease and Cushing syndrome? Do you know the difference between
Yes, if
disease and
ACTH
syndrome?
is
released
increased,
from
then
the
disease
pituitary
is from
gland,
the
it's
thyroid
Cushing
center.
disease.
Yes. When the Cushing syndrome is due to a pituitary cause, then it is called Cushing disease. Okay, remember this difference. When the cause is due to a pituitary adenoma, then that is called Cushing disease. Okay, when there is a secondary cause and that secondary cause is due to pituitary gland, okay, then it is called Cushing disease. Okay. Okay, so because in our case the ACTH levels drops, that means it is pituitary adenoma, not small cell lung cancer. Okay, ACTH level normal decrease, pituitary adenoma, low dose dexamethasone suppression test. Okay, okay, let's move on to the next question. Okay, which of the following additional finding is most likely to be present in this patient? Okay, read the options. Bilateral crackles, elevated jugular venous pressure, maximally dilute urine, perineal status, peripheral edema. Okay, now read the whole question and try to find all the abnormal things in this patient. Okay, 60-year-old man, altered mental status, nagging cough. The first abnormal thing is altered mental status. Second abnormal thing, nagging cough that seemed to worsen over the past several months. Experiencing occasional dizziness earlier this week. Okay. Fourth thing, the patient has becoming increasingly confused and does not make any sense at all. Okay. History of smoking for the last 40 years. Okay. The patient is incoherent and but has otherwise normal neurological examination. Let's see the laboratory findings. Sodium levels are 120. That are way less. The patient is hyponatremia. Okay. Burn levels are normal, creatinine levels are normal, calcium levels are normal, glucose levels are normal. Plasma osmolarity is 250, which is also way less. Usually it is 280 to 300. Okay. Urine drug screen is negative. Chest X-ray reveals a mass in the right lung. Okay, there is a mass in the right lung and their sodium levels are dropped and the plasma osmolality level is less. The patient is confused. Okay, so what do you think is the diagnosis here? Peripheral edema, non-maximally dilute. What do you think is the diagnosis here?
It's small cell lung cancer.
Yes,
Yeah, the
but
patient has a lung cancer.
secreting
That can
ATH.
explain the mass in the right lung. That can explain the cough that patient has for the last several months, and that can also explain that the patient has a smoking history for the 40 years. Okay, so these things, and now the question started to make sense. Okay, small cell lung cancer is a has a tendency to produce different types of hormones. We call these paraneoplastic syndromes. Okay, so what type of hormones that small cell lung cancer can produce? What are the
SIADH.
ACTH,
SI,
other
ADH also.
SIADH.
ADH, other than ADH, and we know that ADH can cause high levels of ADH can cause low levels of sodium. Okay, and and low levels of sodium can cause confusion, profound hyponatremia, can cause the headache, can cause the weakness, can cause the altered mental status, which are all present in this patient. Okay, so we have solved 50% of the question, that the diagnosis is SIADH, and we have the patient has SIADH due to the small cell lung cancer, and the patient small lung cancer due to because the patient is smoking for the last 40 years. Okay. Okay, now everything started to make sense. Now we have to see which of these options is much more consistent with SIADH. Okay, in SIADH, we are going to see increased water reabsorption from the kidney, right? Because we have anti-diuretic hormone. ADH stands for anti-diuretic hormone. When you give diuretics, you are going to see increased urination. And when you are giving an anti-diuretic thing, the diuresis is going to be less. Okay. So option C will not be the right answer, right? Because now we are going to see maximally concentrated urine.
Concentrated urine.
Yes. Okay. Okay. So bilateral crackles at the lung base. The patient is not has a, does not have heart failure, right? The patient has lung cancer, right? Okay. So A is not the right answer. A would be the right answer if the cause is heart failure, right? Okay, we are left with B, D, and E. Peripheral edema, elevated jugular venous pressure, and normal appearing volume status. Okay, what will happen to the volume status in
What about
SIAD?
Euvolemic.
normal?
Volume status will be
Normal.
Normal.
why the volume status is going to be normal?
Because of the absorption of the water in the collecting duct by ADH.
Osmolarity decrease.
See, characterized by euvolemic hyponatremia. Euvolemic means normal blood volume status. Okay, hypervolemia, high blood volume, hypo, less blood volume. Why there is normal volume hyponatremia in SIADH? Because the body's other systems are working normally. How does the aldosterone will respond to high blood volume, high water retention? It will decrease its secretion. And how does ANP and BNP are going to respond? They are going to increase its secretion, and due to which you are going to see a compensatory increase sodium secretion and normalization of the extracellular fluid volume, leading to euvolemic hyponatremia. Okay, because the body's other systems are working normally. It is the same like when you are seeing hypercortisolism due to an adrenal adenoma. How does the pituitary gland will respond? By decreasing the ACTH levels. Same when you are going to see high water retention, how does your other system is going to respond? Your aldosterone is going to decrease its release. ANP and BNP are going to increase its secretion, and due to that, what will happen? Sodium secretion is going to increase. Normalization of the extracellular fluid volume, because the ANP and BNP do what? They are going to excrete out the extra fluid. Okay, and in this way, you are going to see a normalization. Okay, what are the SIADH causes? Ectopic ADH, small cell lung cancer. Okay, small cell lung cancer. Okay, so what will be the right answer here? Normal appearing volume status. Euvolemic hyponatremia. The patient has SIADH. Okay.
Dr. Stan, if you don't mind, can you repeat it?
Okay, so the patient has a mass in the right lung. Okay, that mass in the right lung can only be explained by a lung cancer. Okay, you cannot explain that mass through heart failure. Okay, that's why option A and option number B does not make sense. Okay, because these two options cannot explain the mass in the right lung. Okay, and after we explain the mass that it is a lung cancer, we know that in small cell lung cancer there is an increased production of ADH. Okay, and due to that ADH, we are seeing less sodium here. Okay, there is hyponatremia here, and due to that hyponatremia, that can explain the confusion here, the altered mental status here, because we know when there is a patient has a profound hyponatremia, that can lead to altered mental status, which is happening in this patient. Okay. And now we have to find an option which is much more consistent with SIADH. Okay, so we have to see which of the, now there are two options. Option number D, now we are left with two options, D and E, and we have to see what will happen to the volume status in SIADH. And we have learned that the volume status is going to be normal. Why normal? Because aldosterone, it is called aldosterone escape mechanism, because in this aldosterone secretion is going to be less, because the adrenal glands will respond to the increased water retention by decreasing the aldosterone secretion. And when there is increased and when there is increased water levels, and there is going to be increased stretch on the atria and the ventricles, because now the volume is increased. And how they are going to respond to that? By increasing the ANP and BNP levels. Okay, and this is going to cause the increased urinary sodium secretion and normalization of the extracellular fluid volume. They are working as a compensatory mechanism. Okay, because the other
Thank you
body
so much.
systems are going to work in normally. Okay, that's
Thank you.
why we are going to have a euvolemic hyponatremia. Okay. Start from the last part. Which of the following is most likely present in this patient? Adrenal cortical hyperplasia, medullary hyperplasia, Leydig cell tumor, pituitary adenoma, seminoma. Okay. Now read the whole question. Okay. 4-year-old boy is brought to the clinic. Pubic hair.
جالو زوج.
The body had a recent growth spurt and is taller than a 5-year-old boy. Okay. 5-year-old brother. The person was recently mentioned he has body odor. Okay, the patient has body odors, taller. Okay, height is at 95th percentile. Examination reveals sparse growth of long pigmented hair at the base of the penis in both end and in both axilla. Okay, testes are present bilaterally and appear normal. Reveals high serum concentration of 17-hydroxyprogesterone levels. The 17-hydroxyprogesterone levels are elevated. Okay, and testes are present bilaterally and they appear normal. And we are seeing increased signs of secondary sexual characteristics. Okay, there is precocious pre-puberty here, and there is increased 17-hydroxyprogesterone here. Okay. Okay. Is the 17-hydroxyprogesterone is going to be elevated in a Leydig cell tumor? Is it going to be elevated in a Leydig cell tumor? No.
No.
And in Leydig cell tumor, you are going to see a mass within the testes, right? Is there any mass within the testes? No.
No.
Right? Okay. In pituitary adenoma can cause increased increased level of GnRH, and due to GnRH there is increased LH, and due to LH there is increased testosterone. Okay, but that can not also explain the increased levels of 17-hydroxyprogesterone, right? That cannot also explain the higher levels of 17-hydroxyprogesterone. Okay, so pituitary adenoma cannot be also. Seminoma is a cancer. Okay, and in seminoma you are not going to see increased testosterone. Seminoma is a cancer of testes. You are going to see a mass within your testes, but it does not causes increased level of testosterone. Okay, now we are left with adrenal cortical hyperplasia and adrenal medullary hyperplasia. What hormones are produced by adrenal medulla?
Norepinephrine and epinephrine.
Norepinephrine and epinephrine, they are not related with the increased levels of steroid, increased level of testosterone or male sex hormones. Okay, because in the adrenal cortex, three hormones are produced. First one is aldosterone, second one is cortisol, and the third one is DHEA, dihydroepiandrosterone, which is a precursor molecule for the testosterone. Okay, so the right answer is adrenal cortical hyperplasia. Okay, adrenal cortical hyperplasia. Okay, so there are two types of adrenal cortical hyperplasia. One is the non-salt wasting type, and the other is the salt wasting type. Okay, in both of them, the severe one, you are going to symptoms at a very early age, like at an age of 1 to 2 weeks. Okay, and in the other one is you are going to see symptoms at a later age, like our patient is starting to show symptoms at an age of 2 to 4. Okay, here we are seeing increased body odor, increased pubic and axillary hairs, and rapid growth. Okay, but all of these are seen at an age of 2 to 4. Okay, that is non-salt wasting type. Okay, that is going to show you symptoms at the later age. Okay, this is congenital adrenal hyperplasia. Okay, 17 hydroxy progesterone is going to be increased. Okay, like if you have a deficiency of 11 beta hydroxylase, 11, so all the things which are before that enzyme are going to be elevated. Okay, 11 beta hydroxylase deficiency, 17 hydroxy progesterone is before the 11 beta hydroxylase. So 17 hydroxy progesterone levels are going to get elevated. If you have a deficiency of 21 hydroxylase, all the things which are before 21 hydroxylase, progesterone is going to get elevated, 17 hydroxy progesterone is going to get elevated. Okay, in this you will also going to see increased 17 hydroxy progesterone. If you have 17 alpha hydroxylase deficiency, 17 hydroxyprogesterone is also going to get elevated. So this is a common factor in all the three types of enzymes which are deficient usually in the congenital adrenal hyperplasia. Okay, so 17 hydroxyprogesterone is elevated in all of these three. Okay, so when you are going to see increased 17 hydroxyprogesterone, there can be three enzymes: 21 hydroxylase, 17 alpha hydroxylase, and 11 beta hydroxylase. Okay, in 17 in 21 hydroxylase, you are going to see precocious puberty in the childhood. Okay, let's now see what happens in 21 hydroxylase at the point B. So progesterone conversion to 11-deoxycortisone is stopped, and 17-hydroxyprogesterone conversion to the 11-deoxycortisol is going to be stopped. Okay, when your body is no longer producing cortisol, what will happen to the ACTH levels? If your body is not producing
Increase.
cortisol,
It's
they are going to
increase.
get increased. Okay, so same, if your body is not producing aldosterone or cortisol due to a deficiency of one enzyme, all the things which are before that are going to increase. So progesterone is going to get elevated, 17 hydroxyprogesterone is going to get elevated, and when you are going to see increased 17 hydroxyprogesterone, that increased level of 17 hydroxyprogesterone are going to convert it into something. They are going to convert into what? Testosterone. Okay, and increased testosterone, due to which we are going to see precocious puberty here. Okay, okay. See, there are classic salt wasting type, classic non-salt wasting type, and non-classic late onset. Okay. 21 hydroxylase is the most common enzyme which is usually deficient in congenital adrenal hyperplasia. Okay, after initial assessment, the appropriate interventions are initiated. Targeted suppression of which of the following hormones is the best next step to limit the androgen production? If we suppress the production of which hormone, we can limit the overproduction. What a Okay, the increased levels of the male sex hormones in these patients are due to congenital adrenal hyperplasia. Because in congenital adrenal hyperplasia, we are going to see less cortisol, less aldosterone, right? And due to which what happens? The ACTH levels are going to get elevated, right? And when the ACTH levels are going to get elevated, the increased ACTH are going to come to the adrenal gland, and they are going to they are going to signal them to increase the production of aldosterone and cortisol. But the main enzyme is in deficit there. They cannot produce cortisol and the aldosterone. But all the precursor molecules that are there before that enzyme are going to get elevated. Okay, so if we control the ACTH levels, if we suppress the ACTH levels, we will be able to stop the signaling to the adrenal glands to increase. We can stop the signaling to the adrenal glands to increase the production of the cortisol or aldosterone, and in this way we can stop the increased testosterone levels. Okay, so even if prolactin is not the main issue here, right? LH is not the main issue here. Okay, cortisol is not the main issue here, right? Cortisol is less in this patient. LH is normal. LH is going to be low in this patient. Prolactin is going to be normal in this patient. ACTH is going to be high in this patient. In the question, he is asking targeted suppression. Okay, if he is asking suppression, that means that thing should be in high amount. Okay.
Dr. Hasnain, we can't hear you. Dr. Hasnain, we can't hear you.
Okay, sorry. Okay. Can you hear me now?
Yes, we can hear you now. Yes.
Okay. Okay. So, because the main cause of the symptoms in this patient are adrenal androgens, dihydroepiandrosterone. Okay. It is not due to the testosterone. Dihydroepiandrosterone is converted peripherally into testosterone, but the main cause is increased production of adrenal androgens. Okay, so if you even block the testosterone, you will not block the increased production of dihydroepiandrosterone. Okay, we have to block the production of dihydroepiandrosterone, the adrenal androgens, and that can only be blocked by blocking the ACTH levels. Okay, that's why testosterone is not the answer here. The answer is ACTH. Okay, see this graph? You can see that when the 21 hydroxylase is deficient, progesterone is going to get elevated, 17 hydroxyprogesterone is going to get elevated, and that is and all the dihydroepiandrosterone is going to get elevated. Androstenedione is going to get elevated, right? Okay, let's move on to the next question. The patient is most likely deficient in for an enzyme normally present responsible for which of the following? Let's see. Okay. Read the question. "26-year-old woman, delivery was incomplete. Clytromegaly. The patient is a female. Okay, so he has himself mentioned that the patient has congenital adrenal hyperplasia. Okay, abdominal imaging shows bilateral adrenal hyperplasia. What are the three enzymes which are usually deficient in congenital adrenal hyperplasia? 21 alpha hydroxylase, 11 beta hydroxylase, and the 17 alpha hydroxylase. Okay, and we know that all of these three enzymes, they are not involved in cholesterol into pregnenolone, right? None of them is involved in this, right? None of these three enzymes is involved in DHEA conversion into androstenedione. Okay, and none of these enzymes is involved in testosterone conversion into dihydrotestosterone. We are left with two options, C and D. Our patient has increased steroids, right? That's why he has clytromegaly. Okay, the patient is a female with increased male androgens. Okay, that can explain the clytromegaly here. That can explain the partial fusion of the labiosacrotal folds here. Okay, because the patient is experiencing increased virilization. Okay, the patient is experiencing increased levels of increased level of androgens. Okay, so we have to find out in which of these enzyme deficiency we are going to see increased level of androgens. Okay, now let's see. Okay, sex hormones are elevated in two enzyme deficiencies, 21 hydroxylase deficiency and 11 beta hydroxylase deficiency. Okay, you can see clearly they are not going to be elevated in 17 alpha hydroxylase. Okay, and 17 alpha hydroxylase is involved in where? In progesterone conversion into 17 hydroxyprogesterone. Okay, progesterone into 17 hydroxyprogesterone. Okay, so we know that now. Let's open option. Progesterone into 17 hydroxyprogesterone. In this, the enzyme involved is 17 alpha hydroxylase, and we know when 17 alpha hydroxylase is deficient, we are not going to see increased level of androgens, right? So the right answer is going to be C, progesterone into 11 deoxy progesterone into 11-deoxycorticosteroid. Which enzyme is involved here? 21 hydroxylase. And we know in 21 hydroxylase, sex hormones are going to be elevated. Okay, and you are going to see precocious puberty and XX virilization. Okay, because now the patient is going to experience increased level of male sex hormones. Okay. Okay, let's move on to the next one. So you have to memorize the whole of this chart. Okay, it's very important. Okay.
Hello, doctor. Your battery is about to die.
Okay, I will do something about it. You people read the question. Which of the following is most likely to be present in this patient? See the options. Read the whole question. Okay. The patient is 32-year-old. Vision problem. The patient has vision problem. Okay.
We can't
So we're not
see
seeing
the
your
screen.
screen.
Just share the screen.
Okay, you are not seeing my screen. Sorry. Start broadcast. Can you see it now?
Yeah.
Yes.
Okay, the patient has vision problems, right? The patient has near misses while driving, having been nearly hit by the cars coming from both right and left side. He also reports frequent headaches. The patient has no prior medical conditions. He has no use of tobacco, alcohol, deficits in the bilateral temporal visual field defect. Okay. Extraauricular muscles movement are bilaterally intact. Okay. Which of the following is the most likely to be present in this patient? Okay. Bitemporal hemianopia. Bitemporal hemianopia. That's a okay. That can explain the near misses while the patient is driving. Okay, and we know by optic chiasma. Optic chiasma is located where?
Cella near under pituitary.
It is located on the sides of the pituitary gland, right? So whenever we are going to see increased size in the pituitary gland, it is going to cause the compression at the optic chiasma, right? Bitemporal hemianopia. In bitemporal hemianopia, what thing is damaged? Optic chiasma, right? Optic chiasma is damaged. See, this is the pituitary gland. This is the pituitary gland. Okay, and see the optic chiasma. These are the optic chiasma. Optic chiasma just above and on the sides of the pituitary gland. So any issue with the pituitary gland is going when the pituitary gland size is going to increase. Like if the patient has pituitary adenoma, what will happen? It will going to cause pressure on the inner side of the optic chiasma, and due to which you are going to see the visual field defects. Okay. Okay. Why there is headache? The headache is due to the increased, when the pituitary size is going to increase, it is going to cause stretch on the meninges. And we know meninges have pain receptors, right? And when the meninges are stretched, you are going to feel what? Headaches. Okay. Okay. Now the bitemporal heminopia and the visual field defects are explained, right? The headache is explained. Okay. Which of the following additional finding is most likely to be present in this patient? Enlarged jawbone, excessive urination. Okay, we know that it is pituitary adenoma, right? Okay, do you know what is the most common type of pituitary adenoma?
Prolactinoma.
Prolactinoma. Prolactinoma is the most common the hormonally active adenoma. Okay. Most common pituitary adenomas which are functional are prolactinomas. Okay. Okay. What will happen to the GnRH? What will happen to the GnRH when there is when there is increased prolactin?
Decrease level.
Decrease.
They are going GnRH is going to decrease. What will happen to the FSH LH levels?
Decrease.
FSH LH levels is going to decrease. Okay, prolactinoma. Okay. In the new book, there's okay. Most commonly from what? Lactotropes. Hyperprolactinoma. Okay. Pituitary adenoma, most common type is from lactotropes. Okay, that's a okay.
We can't hear you, Dr. Slan.
Okay. Enlarged jawbone. Enlarged jawbone is going to be heard in when there is increased growth hormone,
Growth
right?
hormone.
Excessive urination. Excessive urination is going to be heard when there is increased
Diabetes
Diabetes
AD
insipidus.
yes, heat intolerance for thyroid hormone.
Hypothyroid.
Skin hyperpigmentation. Skin hyperpigmentation. Skin hyperpigmentation is can be seen when
Cushing syndrome.
when there is adrenal insufficiency. Whenever you are going to
Insufficiency.
see increased ACTH levels, because ACTH is derived from what molecule? POMC. And when there is increased POMC, we are going to see increased MSH as well, due to which we will going to see skin hyperpigmentation. Skin thinning. Skin thinning is going to be present in what?
Cushing syndrome.
Cushing syndrome.
Cushing disease.
Right answer is decreased libido. Okay, electrotropes, and due to which we are going to see. Okay. Okay. Prolactinoma classically presents as lactoria, amenorrhea, because there is less decreased bone density due to suppression of estrogen in females, and decreased libido in infertility in males. Okay. Okay. Let's move on to the next question. The abnormal tissue most likely originated from which of the following? A 40-year-old woman is evaluated for intermittent headaches, insomnia, diaphoresis. Okay, see the options. The patient has intermittent headaches. Okay, insomnia, diaphoresis, unintentional weight loss, and intermittent headaches. No other medical problems, takes no medication, does not use tobacco, alcohol, or illicit drugs, and has no significant family history. Have a neoplastic mass producing excessive amount of a hormone, producing excessive amounts of hormones that are causing her symptoms. Surgical resection of the abnormal tissue is performed with no operative complication. Shows membrane-bound secretory granules positive for synaptophysin, chromogranin, and neuron-specific enolase. Neuron-specific enolase. Okay. Do you know in which hormones, in which tumor you are going to see these markers positive?
Neuroendocrine.
Yes.
Neuroendocrine.
Yes. Okay. First comes to the adrenal cortex. Adrenal cortex arises from ectoderm, right? Adrenal cortex arises from ectoderm, and adrenal medulla arises from
Neural crest.
mesoderm, neural crust cells. Okay, neural crust cells. So they have a link with neurons, right? They have a link with neurons. Okay, and the marker is chromogranin, synaptophysin, and neuron-specific enolase. Okay, so the intermittent diaphoresis and headache, these are the symptoms of what tumor? Intermittent. All of these can be explained by one tumor. Pheochromocytoma, right? Open pheochromocytoma. Okay, see. First see the markers here. Okay. Chromogranin, synaptophysin, and neuron-specific enolase. Okay. The patient has episodic, very important. Episodic hypertension. Our patient has intermittent headaches, insomnia, diaphoresis, weight loss. All of these symptoms are intermittent. Okay. Increased blood pressure is going to cause increased perspiration, increased palpitation, increased pallor. Okay, all of the symptoms which we are seeing in this patient can be explained by pheochromocytoma, and the tumor markers are also present in pheochromocytoma, synaptophysin, chromogranin, and neuron-specific enolase. Okay. So what will be the answer here? Pheochromocytoma. If the diagnosis is pheochromocytoma, what will be the answer here?
Adrenal.
Adrenal medulla.
B.
Adrenal medulla. B. Right? Adrenal medulla. Most common tumor of what? Adrenal medulla. Okay. Derived from the chromaffin cells, rise from the neural crest cells. Okay. Let's move on to the next one. Okay. The patient most likely has which of the following conditions? Okay, see the options. Now comes to that 14-year-old boy. Painless nodules on his lips and on his tongue. Okay. The lesion appeared several months ago and have been progressively enlarging. Okay. Total thyroidectomy due to what? Is some type of thyroid mass, can be thyroid cancer, due to which the patient has to do a thyroidectomy. Okay. The patient is tall, slender, with disproportionately long arms and legs. Okay. Fingers are also long and thin. Okay. And there's joint laxity. Okay. That is the third. Okay. Okay. So you are seeing three things here. First, there the patient has long arms and legs, long and thin, fingers are long and thin, joint laxity is present. Can you tell me in which condition we usually see long
Marfan
arms and
syndrome.
legs? In the
Marfan syndrome.
Marfanoid syndrome. Okay. In the Marfanoid syndrome, we usually see this. Okay. The patient has small, soft, flesh-colored papules on his lips and tongues. There are painless nodules on his lips and tongue. Can Marfanoid syndrome explain this finding?
No.
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 Marfanoid syndrome cannot explain this finding. Can Marfanoid finding explain the patient thyroid mass for which he has to done the thyroidectomy?
No.
No.
Okay, so it is not Marfanoid syndrome. The patient has some Marfanoid features, but it is not Marfanoid syndrome. Okay. Okay, neurofibromatosis can explain the fibromas, the mucosal flesh-colored papules, but neurofibromatosis cannot explain the thyroidectomy the patient has, the Marfanoid habitus the patient has. That cannot be explained the neurofibromatosis type 1 and 2. And Ehlers-Danlos syndrome can also does not explain this. Now comes to the men syndromes. Men type 1 and men type 2B. Okay. In men 1, we are seeing 3 Ps.
Three
Pituitary,
piece.
pancreatic, and parathyroid. Okay. And men 2B. Now see men 2B. Medullary thyroid carcinoma. Our patient has a thyroidectomy. That can be explained by this. Okay. Mucosal neuromas, oral and intestinal ganglioneuromatosis. That can explain the flesh-colored papules on the patient lips. Okay. Associate with Marfanoid habitus. All the three findings in our question can be explained by men to be, right? So what would be the right answer here? Men to be. Okay. Let's move on to the next one. Okay. Okay, suppression of joy. Serum somatostatin levels are highly elevated. Okay, we have to tell which of the hormone is directly involved in the formation of, in the function of gallbladder and that can stop the formation of the gallstones. Okay, because he is asking suppression of. Read the last line very carefully. Okay, try to find what is exactly trying to ask us. Suppression of which of the following hormone is most likely responsible for biliary stones? Biliary stones. Okay, glucagon and insulin are mainly involved in what? In the control of the glucose levels, right? Gastrin is involved where? In the stomach. It is involved in the production of stomach acid. Growth hormone has nothing to do with the gallbladder, right? Okay. We are left with two: secretin and cholecystokinin. Cholecystokinin. Which one of these hormone is involved in the function of the gallbladder?
Cholecystokinin.
Cholecystokinin. What is the name of the what is the other name of the gallstones? What is the other names of them?
Cholelithiasis.
Cholelithiasis. Cholelithiasis. Cholecystokinin. You can see the similarity here. Cholecystokinin. Where is the hormones? Okay. Cholecystokinin. What are the function? Increased gallbladder contraction. Okay, if that hormone is going to be less, then the gallbladder contraction will be less. And if the gallbladder contraction is going to be less, we are going to see less release of the bile into the intestine. And when there is stasis of bile in the gallbladder, what will happen? You are going to see increased gallstone production. Okay, and why there is less CCK in this person? Because of the increased somatostatin. Okay, because of the increased somatostatin. So the right answer is CSK. Okay, let's move on to the next one. Which of the following will best in the diagnosis in this patient? Okay. Now, first try to see all the abnormal thing in this patient. The patient has recent weight loss. Okay, I've been really thirsty. I've been really thirsty. It does not matter how much I eat, I keep losing weight. There is polyuria here, polydyspia here, drinking lots of water, and the patient is really thirsty. And she is going to washroom she's going to washroom frequently. Polyuria, polydyspia, and polyphagia as well, and weight loss. That I'm going to get dropped from the team if I do not get myself together. Sexually active, further diagnosed with colon cancer. Okay, what do you think is the most likely diagnosis here? Polyuria,
Diabetes.
polydyspia, polyphagia. The three P's.
Diabetes.
HbA1c level.
Type
Yes,
1 diabetes.
the patient has type 1. Most likely, the patient is suffering from type 1 diabetes. And that can explain all the four findings in this patient. Okay, and if the patient, though, so what is the first test we usually do is type hemoglobin
Hemoglobin A1C.
A1C. Okay, polydyspia, polyuria, polyphagia, weight loss. Okay, type 1C. Type 1 diabetes. Okay, so three P's: polydyspia, polyuria, and polyphagia. Okay, and weight loss in type 1A, type 1. Okay, so all of these findings are present in this patient. Okay, let's move on to the next one. And the test we usually do is HbA1c. We can do the other test as well. Okay, let's move on to the next. This patient most likely has deficiency of which of the following. Again, the question is, okay, 13-year-old.
17 alpha hydroxylase.
Temperature is okay. I'm saying good lack of secondary sexual characteristics and a blind vagina. Okay. And there is hypokalemia and low testosterone and estradiol levels. Okay. And the patient has hypertension. Hypertension and hypokalemia.
Aldosterone.
Aldosterone. Whenever you see hypertension, hypokalemia, the first test you will do is for aldosterone levels. Okay, hypertension and hypokalemia, and our patient has hypertension and hypokalemia. Okay, that means the aldosterone levels are high, and other than aldosterone levels high, what is the other thing that is also high? That is low. The patient has less sex hormones. Okay, now we have to find an option in which the aldosterone is high and the sex hormones are less. Okay, if the patient has a deficiency of 5-alpha reductase, 5-alpha reductase is involved where?
It's involved in testosterone
Conversion. Estrogen.
conversion.
It is involved in the conversion of testosterone into DHT. Okay, it is involved in the conversion of testosterone to DHT. Okay, so because DHT is mainly responsible for the external genitalia development. Okay, so but if that is blocked, that cannot explain the high aldosterone levels, right? That cannot explain the high aldosterone levels. Okay, we are left with three options: 11, 11, 17, 21. Okay, 2022 the decimal levels is not involved, is involved in conversion of cholesterol into pregnenolone. If that is absent, then even the aldosterone would be less. Okay, and we know there are three types of enzymes which are usually absent in congenital adrenal hyperplasia: 17, 11, and 21. Now you have to find out in which the aldosterone is going to be high and sex hormone is going to be less. In the previous question, in which we do 21 hydroxylase deficiency, what will happen to the sex hormones in 21 hydroxylase deficiency? We did a question increase, and in these questions, sex hormones are less.
Decrease. So
Okay,
17
so
and
we are left with
hydroxylase.
two options: 11 and 17. Okay, in one of these, the sex hormones are going to be less. Which one is this?
17 deficiency.
17.
See, 17 alpha hydroxylase. Sex hormones is less, is only one type of deficiency, and the other two, they are going to be high. Okay, and due to which you are going to see in females lacks secondary sexual characteristic, and in males atypical genitalia and undescended testes. Okay, and what will happen to the blood pressure and the potassium? Potassium is going to be low. And okay, aldosterone is low in this patient in 17 alpha hydroxylase. But even then, the potassium is low and blood pressure is high. Why? Why the potassium is high? Potassium is low and blood pressure is high.
Sodium.
Because of the increased 11-deoxycorticosterone. It is a precursor molecule. Okay, when it works, when it is in large amounts, it will work the same like the aldosterone. Okay, like when cortisol is in very large amount, it works exactly like the aldosterone. Okay, cortisol also has has a built-in mineralocorticoid activity as well, but that activity will be much more profound when it is in very large amount. Same will happen with 11-deoxycorticosterone or corticosterone. When they are going to be in very large amounts, you are going to see increased mineralocorticoid activity. Okay, so that's why you have less potassium, increased blood pressure. Okay, so there is a mnemonic there. If deficient enzyme starts with 1, like 11 starts with 1, 17 starts with 1. It causes hypertension. Okay. And if deficient enzyme ends with 1, it causes virilization. Okay. If you remember this mnemonic, it will help you a lot. Okay. If starting is 1, you are going to see increased blood pressure. Increased blood pressure. If ending is 1, 21, end is 1, 11, end is 1, and start is also 1. You're going to see increased blood pressure and increased sex hormones. Okay. This is a very good mnemonic. It will help you a lot. Okay. Okay. So what will be the answer here? 17 alpha hydroxylase. Okay. And it is a non-classic type. Okay. Which of the following best is most likely associated with this patient condition? Non-healing ulcer on his right foot. Okay, non-healing ulcer on his right foot. Recurrent high blood pressure readings. BMI is also elevated. Bilateral symmetric. Okay. Is it type 2 or what is the diagnosis here?
Type 1 diabetes.
Type 2 diabetes.
The patient has diabetes. Okay. Is it type 1 or type 2?
Type
Type 2.
Type 2.
Type 2.
Type 2.
What is the age of the patient? 65.
65
years.
What is the BMI? 37. Right?
Yes.
Insulin resistant.
High minor deficiency.
Yes, it is going to be type 2 deficiency. Right? Because, okay. Now you have to tell me which of these is much more consistent with type 2 circulating anti-islet antibodies. Circulating antibodies develop in type 1 or type 2? Which one is
Type 1.
Type
considered?
1.
Type 1.
Type 1. And we know in this condition that it is type 2.
2.
Ketoacidosis develops mostly in type 1 or type 2?
Type
Type
1.
1.
Type 1. Okay. Strong linkage with HLA class 2 gene makeup, islet. Okay. Now let's see. Oh, no. Type 1. Always less than 30, greater than 40. Our patient age is 64. Resistance to insulin. Association with HLA system. Yes. No. Type 1 is associated with the HLA system, right? Okay. So D is not the right answer. Okay. Now see the histology. Islet leukocytic infiltration is seen in when? In type 1.
Type 1.
Islet amyloid polypeptide deposit seen in what?
Type 2.
2. Now tell me the answer. Which one is going to be the answer?
B.
B is going to be the right answer because it is type 2. Okay.
Yes.
Okay, let's move on to the next one. Which of the following additional laboratory findings are most likely to be seen in this patient? Recurrent vomiting. The patient has recurrent 1 week old boy, recurrent vomiting, poor feeding. Blood pressure is 58/30. That means the blood pressure is low. Pulse is high. The patient started appearing with sunken anterior frontanella. Okay. Sodium is also low. Potassium is high. Okay. Okay. So okay, let's start with the potassium levels. If your aldosterone is high, what will happen to the potassium levels?
Less.
Low.
They are going to be low.
Low.
That means the aldosterone is low in this patient, right?
Yes.
Yes.
So option number B is eliminated. Okay. The blood pressure is 58/30. The patient has sunken anterior fontanelle. The patient has dry mucous membranes. That means all the patient has less fluids. The patient has less blood pressure.
Dehydration.
Dehydration. And for dehydration, both the aldosterone and the cortisol should be less or high.
Less.
So
Both of them
Less.
should be less.
less.
Okay, both of them should be less. Option number E is also eliminated. Okay, what will happen to the ACTH levels if the aldosterone and cortisol are less? How
High.
the yes, ACTH is going to be high.
High.
Okay, so we are left with A and C. 17 hydroxyprogesterone. What will happen to the 17 hydro? Okay, if a 17 hydroxyprogesterone is elevated in what enzyme deficiency?
In
In
11 and
11
21.
and 11 and in 21. Okay. In 21, what will happen to the blood? What will happen to the blood level? What will happen to the blood pressure? In
Low.
21,
It
Low.
will increase. Decrease.
it will be decreased.
Decrease.
If deficient enzyme starts with 1, it causes hypertension. Does 21 starts with 1?
No.
No. That means the blood pressure is going to be low here. Okay. Blood pressure is going to be low here. Okay. Aldosterone levels are going to be low here. Cortisol levels are going to be low here. And 17 hydroxyprogesterone levels are going to be high.
Increased.
Okay. So it's 21 hydroxylase enzyme deficiency. So what will be the answer here?
A.
So that can explain the low sodium levels because the patient has less mineralocorticoids, high potassium levels, okay, low blood pressure, sunken anterior fontanelle, dry mucous membrane. All of these findings can be explained by the congenital adrenal hyperplasia. Okay, okay, let's move on to the next one. Okay. The patient has a cold nodule or a hot nodule. The nodule is cold or hot. The nodule is cold. Okay.
It's
Why
cold.
it is cold? Because normal serum TSH levels. That means the patient's nodule is not producing thyroxine hormone. And we know that cold nodules are usually cancerous. Okay. Now comes to the FNAC findings. Cluster of cells with large overlapping nuclei containing finely dispersed chromatin, numerous intranuclear inclusion bodies and grooves as well. In which of these cold nodule it is not cold nodule, okay, it is not adenoma, it is the cancer, okay. In which of these following you are going to see intranuclear inclusion bodies and nuclear grooves? In which of the thyroid cancer? What is the most common type of thyroid cancer?
Papillary.
Papillary.
Pulmonary carcinoma.
Somoma bodies.
Yes. Empty appearing nuclei with central clearing, okay, orphan eyes, somoma bodies, and nuclear grooves. Nuclear grooves. The patient has nuclear grooves, okay, has intranuclear inclusion bodies. The patient has orphan eyes nucleus and nuclear grooves which are consistent with papillary carcinoma. Okay. See the nuclear grooves here, optically clear nuclei as well, and nuclear pseudo inclusion bodies. Finally, dispersed chromatin, orphan eyes. Okay, pseudo inclusion. See the options. Okay. Okay, so our patient has cystic fibrosis, and due to cystic fibrosis, now the patient has increased fasting glucose levels, increased plasma glucose levels. That means the patient developed diabetes, right? And now he is asking how in a cystic fibrosis patient does a patient can develop diabetes? Okay. Okay. Increase in from chronic stimulation by the cortisol and epinephrine. Okay, what happens to the pancreas secretions in the cystic fibrosis? What will happen to these pancreas secretions?
Patients
No,
decreases.
blocked.
Decreases.
Decrease.
Does they
Exocrine
become
secretions
much more
decrease.
viscous? Does they become much more viscous and thick?
Yes,
Yes.
because of
Yes, they are
Yes.
going to become
Very
much
thick.
more viscous. They are going to become much more thick. They are going to become much more dehydrated, right? And due to that, they are going to block the pancreatic duct. Okay, they are going to block the pancreatic duct. Okay, and due to that blockage, we are going to see pancreatic fibrosis and fat infiltration. Okay, which is going to which causes progressive encroachment, disruption, and destruction of the pancreatic islet cells. Okay. Okay. So we are going to see cystic fibrosis. Cystic fibrosis. Pancreatic insufficiency, malabsorption, progressing to endocrine dysfunction, cystic fibrosis related diabetes. Okay. So it is not due to the production of autoantibodies. Okay. It is not due to the production of autoantibodies. Okay. So the main cause of the diabetes in this patient is due to cystic fibrosis. but it is not due to the glucagon secretion or glucagon resistance, like in the type 2 diabetes mellitus.
A.
Nor it is due to the, yes, the right answer is going to be A. Okay. Thick secretion is going to block the ducts which are going to lead to the destruction of the pancreatic islet cells. Low blood glucose concentration. Okay, the patient's blood glucose is, newborn glucose is 30. That means the glucose is less. Glucose would be less if insulin is high or low.
Insulin is high.
High, okay. Let's see what are the other things in this patient. Patient birth weight is 4.5 kg. Okay. The pregnancy was complicated by gestational diabetes treated with insulin. However, the glycemic control remained suboptimal due to maternal non-compliance with insulin and poor adherence to the dietary recommendation. Okay. So, what is the diagnosis here? Okay. Productive methyl macrophobia. Maternal diabetes. If the maternal diabetes is not controlled, the patient has macrosomia. Does our patient have macrosomia?
Yes.
No. No.
The patient birth weight is 4.5 kg.
Oh,
Macrosomia.
kg. Sorry.
Yes.
Sorry, yes.
The patient, does our patient has neonatal hypoglycemia?
Yes.
Yes.
The
Yes.
blood
Yes.
glucose levels are
Low.
30.
30. 30.
And what is the cause? Due to the islet cells hyperplasia. Because what will happen when the maternal glucose is high, because the mother is no longer controlling his glucose level. High glucose levels are going to go where? They are going to go within the baby. Okay, and how does the baby pancreas are going to respond to high glucose levels? By increasing the
Hyperplasia.
islet cells, by increasing the cells which are going to produce the insulin. So it can control the, so it can manage the high glucose levels, right? So due to islet cells hyperplasia. Okay, so now tell me what will be the answer here.
B.
B,
B.
hyperfunctioning pancreas. Okay, that's why the child has low blood glucose, because when the child is inside its mother womb, he is facing high glucose level, and to compensate for high glucose level, he started to producing high levels of insulin. Okay, but when the child is delivered, his pancreas still have that hyper functioning action. Okay, still has that increased number of insulin producing cells, and due to that he's facing low glucose level right now. Okay, okay, polycythemia, adrenal hyperplasia. Okay, okay, 20-year-old woman comes to the minister. There is lethargy here, there is abdominal pain here, there is nausea here. She has polyuria, excessive thirst for 1 day, dysuria and chills over the last few days, but did not seek any medical care until today. Physical examination shows tachycardia and dry mucous membranes. Okay, sodium 130, chloride 93, calcium 10, glucose levels. Okay, if the patient age is 20 years, what is the most likely chance? Does the patient have type 1 diabetes or type 2?
Type 1. Type
Type
1.
1. Right, very. Okay. Type 1 main complication is diabetic ketoacidosis or hyperosmolar
Ketoacidosis.
ketoacidosis. So our patient is suffering from diabetic ketoacidosis, right? And that can also explain the abdominal pain here, the lethargy here, the polyuria here, right? And the glucose levels are 698. And if you measure the anion gap here, what will happen to the anion gap here? Is it going to be high or is it going to be low?
High.
High and
Anion gap is going to be high. Okay? Because you can measure it from using sodium chloride and bicarbonates. Okay? It is higher. Okay. What will happen to the potassium levels?
It will be increased because of less insulin.
Okay, what does insulin do to the potassium levels?
Takes it to the
Insulin.
cells, decreases.
Intracellular increase. Insulin increase the intracellular potassium.
Yes, insulin increase the intracellular potassium, right? Okay. Let me show you the potassium electrolyte. And now we know that the insulin is less, right? Okay, insulin. Okay, shift potassium into the cell. Shift potassium into the cell. Which one are they? Beta agonist, insulins, and alkalosis. Okay. Now, when we no longer have insulin, when we no longer have in type 1, there is no production of insulin. What will happen to the intracellular insulin?
Will be decreased.
Intracellular will be decreased because we no longer have insulin, and insulin main function is to push the potassium in for insulin, in for potassium in. Okay, when we have no insulin, less potassium will move into the cell. So intracellular will be low and extracellular will be high, right? Right? So what will be the right answer? C. Okay? C will be the right answer. Okay? Because we do not have insulin now. Increase cellular uptake of insulin. In mothers with diabetes, excess glucose can cross the placenta and can cause the increased fetal insulin. Okay? Glucose can cross the placenta. Insulin does not cross the placenta. Remember this thing. Okay? Remember this. This is very important thing. Okay. Insulin in ketoacidosis. Insulin non-compliance. Our patient has confusion. Our patient has abdominal pain. Our patient has abdominal nausea, vomiting. Normal and increased serum potassium, but depleted intracellular potassium. Okay, depleted intracellular potassium. Okay, in diabetic ketoacidosis. Let's move on to the next one. Okay, tell me all the abnormal findings in this patient.
Headache, bitemporal hemianopia, prolactin
Headache.
levels high.
Yes.
Yeah.
Prolactin levels high, a bitemporal hemianopia, and headaches. All of these three findings can be explained by what?
Decrease. All of them.
All of these three findings can
Prolactinoma.
be, yes, by prolactinoma, by a
Pituitary
pituitary adenoma. Right.
adenoma.
Okay. And we have learned that what will happen to the GnRH levels when the prolactin levels are high?
Decrease.
Decrease. Decrease.
Decreased. And what will happen to the LH, FSH if GnRH
Decrease.
is less? Then
Decrease.
these are going to be less. Yes. This is prolactin. See the arrow prolactin. It is going from here, here. It is minus GnRH, minus prolactin minus GnRH. It decreases the release of GnRH. If GnRH is less, FSH, LH are going to be less. Okay? You can also see it here. Prolactin decreased GnRH. Okay? Okay. By inhibiting the GnRH formation synthesis. Prolactin. What would be the right answer?
A.
Yeah, decrease. Okay. Okay. Prior to the surgery, additional testing should be performed to evaluate for an abnormality in which of the following organs? A 15-year-old boy comes for a neck mass. The patient first noticed the mass a month ago. Now the mass has progressively enlarged. Okay, there is some type of a thyroid cancer here, right? Him not and affecting the left side TSH on biopsy, the cancer is positive for calcitonin, and the mutation is for germline RET. Calcitonin is elevated in what thyroid cancer?
Medullary.
Medullary thyroid cancer. Medullary thyroid cancer arises from what cells?
C cells. Calcitonin.
From the parafollicular cells.
Parafollicular cells.
Right? From the parafollicular cells, and the parafollicular cells produces what? Calcitonin.
Calcitonin.
Okay, and we know RET mutation is present in what type of men syndromes? Men 2A and men 2B. And in men 1, what type of mutation is present? In men 1. What type of mutation is present in men 1?
Men 1.
RAS.
In men1 gene. What gene? Men1 gene. And the men2 RET. Okay. 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 In men2A and men2B. Tell me the cancers involved in men2A. Two P's and one N.
Pheochromocytoma.
Pheochromocytoma. And the other P?
Medullary thyroid.
Medullary thyroid, and the second P is parathyroid.
Parathyroid.
Parathyroid and pheochromocytoma. Okay. Okay. And in men2B, medullary thyroid cancer and pheochromocytoma. Right? In men2B, medullary thyroid cancer and pheochromocytoma. Right?
Yes.
Okay. So now you have to tell me which of the cancer can be present here. Okay. Adrenal pheochromocytoma arises from where?
B. Adrenal medulla.
Adrenal medulla. Right? It arises from the adrenal medulla. Okay. So the answer would be adrenal medulla. Okay. Pituitary cancer is present in what type?
Men1.
Men1. Pancreatic islets. Pancreatics are present in what?
Men1.
Men1. Okay. Adrenal cortex is not going to be present. Okay. Let's move on to the next one. Okay. Which of the following is the most likely explanation for this patient? Lower than expected hemoglobin A1C levels. Lower than expected. Okay, let's first see what is the 50. Let's first see what are the abnormal findings in this patient. The patient has 6-year history of type 2 diabetes mellitus, taking in metformin monotherapy. Does not use that. He consumes a balanced diet. View of his blood glucose general of the last film. That fasting glucose is 150/80, 180. Laboratory analysis shows hemoglobin A1C of 4%. Further evaluation shows with hemoglobin electrophoresis shows hemoglobin A2 levels of 7.5%, and hemoglobin okay. So he is asking, even when the fasting glucose levels are elevated, why the hemoglobin A1C is less? And do you people know in this specific disease, hemoglobin A2 levels are elevated? Do you know in this specific disease, hemoglobin A2 levels are elevated? They are 7.5% in this patient. Okay, let's first see the reflects average blood glucose over prior 3 months. It can be influenced by the RBC turnover rate. If anything can affect the RBC turnover rate, it can affect the HbA1c. Okay. Now comes to the hemoglobin A2. Okay. So because it is not written in the endocrinology, it is scattered in the alpha thalassemia. Can see beta thalassemia minor. What is elevated? Hemoglobin A2 is elevated in when? Beta thalassemia minor. And we have just read if there is anything which is going to affect the RBC turnover rate, it is going to affect the HbA1c levels. Okay, and in this patient, increased level of hemoglobin A2 can only be explained by only one disease here. Which one is that disease pathology? Which one pathology can explain the increased
Beta
AT?
thalassemia.
Beta thalassemia.
Beta
Beta
thalassemia.
thalassemia minor. Serum calcitonin levels are elevated. Calcitonin levels are elevated in which cancer?
Medullary thyroid.
Medullary thyroid cancer.
Large cell.
Yes. Okay. Medullary thyroid cancer is present in men 2A and men 2B, right? The patient has soft papules on lips and tongues. Arms expand. The arm span expand his height, and the patient has long fingers. The patient has marfanoid hepatitis and mucosal neuromas and medullary thyroid cancer. That is consistent with what type of care? Men 2? Men 2B, right?
2B.
Okay. And what is the what other cancer we are going to see in men 2B?
Pheochromocytoma.
Pheochromocytoma, right? We are
Episodic
going to see
headache.
pheochromocytoma. Medullary thyroid carcinoma present, mucosal neuromas present, marfanoid hepatitis present. The only other cancer is pheochromocytoma. Okay, now you have to tell me which of these out of these option is a sign and symptom of pheochromocytoma.
Episodic headache.
Episodic hyper
Headache.
episodic headaches.
Yes.
Remember the 5 P's of the increased pressure, increased headache, and all these symptoms are episodic, right? So the right answer is going to be what? Episodic headaches. Let's move on to the next one. Which of the following is most likely to occur after the we given the patient high dose dexamethasone. Okay, same like the first question. ACTH levels are elevated. Okay, first read the whole question. Okay. Okay. The patient has difficulty climbing stairs and dyspnea on exertion. Why the patient has difficulty climbing stairs? Due to increased level of steroids. Okay. The patient has a 40 package smoking history, hypertension, chest reveals decreased breath sounds over right lung base, 4 on scale, proximal strength is 4 on a scale of 0 to 5, scattered ecchymosis, skin thinning, that is seen in what? In Cushing syndrome. Okay. The patient has hyperglycemia, again Cushing syndrome. 24-hour urinary free cortisol is elevated. That means it is Cushing syndrome. Okay. Now he is asking what is the main cause of increased Cushing syndrome, increased cortisol here? Is the main pathology is within the adrenal glands or within the pituitary or is it at some other place? If the main pathology is within the adrenal glands, what response of the pituitary gland will be? How pituitary gland will be respond if they are increased cortisol and if the pituitary is functioning normally?
Decrease
It will decrease the ACTH levels.
Decreased. Yeah.
What
ACTH
what
will be
if
decreased.
ACTH levels are high? That means the main pathology is not within the
Pituitary. Within the
adrenal.
Pituitary
Okay.
gland.
Chest X-ray reveals a right lower lobe lung mass. As well. Now we have to
Small cell lung cancer.
yes. Yes. Now we have to find what is the cause of the increased ACTH. Whether it is whether it is pituitary or whether it is some other site. Okay.
Ectopic.
Yes. Okay. So what is high dose dexamethasone? We do the high dose dexamethasone test here. Okay. And the patient has a lung mass. The most likely the cause is Small cell lung cancer, right? Because small cell lung cancer produces ACTH. Okay, and we know when there is ectopic ACTH production, in ectopic ACTH production, if you give high dose dexamethasone, it will not suppress the levels of the ACTH or cortisol, right? They are going to remain elevated, right, in ectopic ACTH secretion. And our case is of ectopic ACTH secretion, right? Okay, tell me, if the cause is pituitary, then which one is going to be the right answer?
Option A.
Then option A is going to be the right answer. Okay, but right now, because it is ectopic, the right answer is going to be E. Okay. In addition to brain imaging, the patient sounds should also be screened for which of the following tumors? Frequent clumsiness for the last 6 months he has repeated my. The patient had bitemporal visual field defect. Bitemporal visual field defect occurs due to compression of what?
Adrenal.
Optic chiasma. Which structure is present close to optic chiasma? Pituitary, right? Yes. So there is some type of tumor within the pituitary gland right here, right? Okay. The patient also has a definitive surgery for the neck surgery. Has a definitive treatment with neck surgery 3 years ago. Okay. The patient has recurrent renal stones. Okay. Recurrent renal stones are seen in what?
Hypercalcemia. Hyperparathyroidism.
Hyperparathyroidism. Okay. And okay, the clumsiness and all of this can be explained by that. Okay. In addition to brain imaging, this patient should also be screened for what? Okay. So what type of men syndrome it is?
It's men one. Men one.
It is men 1. The patient has pituitary. The patient has parathyroid. The only one that is left is pancreatitis. Pancreatitis. Okay, so we are going to screen him for pancreas. Okay. Okay, let's move on to the next one. Which of the following is the most likely cause of this patient condition? A newborn boy was born at 39 weeks gestation by a normal vaginal delivery, has a serum TSH above the normal range and serum thyroxine below the normal range. Okay. 39 weeks gestation and above the TSH levels are above the normal range. That means the patient has hypo or hyperthyroidism. Which one?
High. It can be
TSH are high and T4 are low.
Hypo.
Hypothyroidism. Okay. Okay, let's see option number B. Generalized thyroid hormone resistance. In thyroid hormone resistance, what will be the thyroxine levels? Are they going to be low or high?
High.
High. Okay. A reduced TSH receptor stimulating antibodies. TSH receptor stimulating antibodies. What will happen to the thyroxine level? What will happen to the thyroxine levels?
Increase.
They are going to be
Increase.
high. Okay.
Graves' disease.
Yeah. Okay. They are going to be high. Central hypothyroidism. In central hypothyroidism, what will happen to the TSH levels?
Decrease.
Decrease. Everything.
Okay. We are left with C and D. Reduced thyroid binding globulin and thyroid dysgenesis. Okay. Which one is going to be the right answer?
This is congenital. Congenital.
Yes.
So it will be dysgenesis.
Thyroid dysgenesis. Okay. Okay, let's move on to the next one. Okay, which of the following histological findings confirm a diagnosis of follicular thyroid carcinoma in this patient?
Is it Hurtle cells?
Follicular thyroid carcinoma in this patient. For evaluation of thyroid nodule, painless neck lump. Okay. Okay, in the whole question he has mentioned that it is follicular thyroid cancer. Okay, C cell hyperplasia is seen in what cancer?
Medullary.
Medullary, because C cells
Medullary.
produce what? C cells produces calcitonin. Okay. Cell with empty appearing nuclei, orphan
Papillary.
papillary.
Follicular.
Hurtle cells. Hurtle cells are
Hashimoto.
Hashimoto thyroiditis. Lymphocytic germinal centers.
These are in
Lymphocytic germinal centers.
Also in Hashimoto. Hashimoto.
Okay. Multinucleated giant cells. Granulomas. You are going to see granulomas in what type of thyroid disease?
Hashimoto.
Decovariant thyroiditis.
Decurvence.
Decovariant thyroiditis. We are going to see granuloma formation, and we know in granuloma they are epithelioid cells. They are multinucleated giant cells are involved, right?
Okay.
Granulomatous inflammation. Okay. In Hashimoto, we are going to see Hurtle cells and lymphoid aggregates with the germinal centers. Okay. So we are left with tumor capsular invasion. Okay. Tumor capsular invasion is the right answer. Absence of capsule or vascular invasion, unlike follicular carcinoma. Like in adenoma, there is no invasion, and in follicular, there is invasion. Invades the capsule and the vasculature. Okay, there are only 3 to 4 cancers in our body that spreads through blood, and it is out of these 3 to 4 cancers.
Sorry, sir, your charge is so low.
Yeah, there's no electricity is not here, so my phone is going to shut down after a few minutes. Okay, let's try to do how much we can do within this time, and we will continue tomorrow, and I will give you 1 more hour tomorrow. Okay, so we will be able to cover the remaining questions. Okay, and if hopefully if the electricity power comes back within the time, we will be able to cover the class. Okay, a 46-year-old man comes to the office with a painful rash involving her groin, legs, that has been worsening over the last 2 weeks. The patient has diabetes mellitus. There is a rash and there is a diabetes mellitus. The patient has loose stools, diabetes mellitus, stool, and a rash. Okay, now he has mentioned the characteristic of the rash. Coalescing erythematous plaques with crusting and scaling at the borders and central areas of brownish induration and superficial necrolysis. Superficial necrolysis are necrolytic erythematous rash and diarrhea as well and diabetes as well.
Somatostatin.
See, elevated glucagon.
Yes, this rash is a very specific rash which is going to be seen in glucagonoma, the 6 Ds. The 6 Ds of glucagonomas are elevated glucose, diarrhea, dementia, and the superficial necrolytic migratory erythema. Okay.
Hello.
think we may have lost him.
Yeah, the phone is freezing. That's why.
Can anyone tell that from where we received the records of the class?
I think they are available for limited peoples. You can talk with Dr. Ahmed or Dr. Hamza for that.
Okay, thank you.
So we should leave the session. Is out of time.
I think we have to leave because he told that the phone is turning off. We can continue it for tomorrow.
Thank you, guys. Have a good day.
Oh, shit. Okay.